Well, hello, everyone. Just a pleasure to be here with everyone. And man, what a day. It's been just such a fun day two of Eyes on Glaucoma. Day one was a blast. I think I'm having even more fun today. And my name is Justin Schweitzer. I'm an optometrist at Vance Thompson Vision in Sioux Falls, South Dakota. And I'm going to be moderating a session here on hot topics in glaucoma with really three experts in the field of glaucoma. And I couldn't be happier to be on this panel with these three. And really, you're not going to have to hear much from me. You're going to get to hear it from these three. And I'm looking forward to it. So without further ado, I'd love to introduce each one of these glaucoma experts. And number one, I'm going to start with Dr. Danica Marrelli, who is a clinical professor and assistant dean of clinical education at the University of Houston College of Optometry, where she serves as the director of medical eye service. She's a diplomate in the glaucoma section of the American Academy of Optometry and currently the vice president of the Optometric Glaucoma Society. Thanks for being here, Danica. I really appreciate it and all you've done for Eyes on Glaucoma these last 2 days.
My pleasure.
And then I'd like to introduce Dr. Jessica Steen, who is an assistant professor at Nova Southeastern University College of Optometry, where she serves as the director of the glaucoma service at the college's Eye Care Institute. Dr. Steen teaches the course in glaucoma and ocular pharmacology at NSU, where she has a special interest in pharmaceutical and health policy. Dr. Steen also serves as a primary care with emphasis on ocular disease residency coordinator. She graduated from the University of Waterloo School of Optometry and Vision Science and completed her residency in primary care with emphasis on ocular disease at Nova Southeastern. She's a fellow of the American Academy of Optometry, a diplomate of the American Academy of Optometry, a member of the Optometric Glaucoma Society, and currently serves as the president of the Palm Beach County Optometric Association. Jessica, thanks so much for being here with us. Really excited to have you as part of this.
Thank you, Justin. My pleasure.
And then finally, Dr. Constance Okeke is an Ivy League trained board certified ophthalmologist specializing in glaucoma and cataract surgery. Dr. Okeke earned her college and medical degree at Yale University, completed her ophthalmology residency at the Wilmer Eye Institute of Johns Hopkins University, and then went on to complete a fellowship in glaucoma at the Bascom Palmer Eye Institute. She serves as a lead glaucoma specialist at Virginia Eye Consultants and is also an assistant professor of ophthalmology at Eastern Virginia Medical School in Norfolk, Virginia. She has 2 decades of glaucoma experience ranging from cutting-edge research, mastering minimally invasive glaucoma surgical techniques, MIGS, and training other doctors, writing and speaking on various podiums nationally and internationally about the latest in glaucoma medical surgical treatments. Dr. Okeke also has an educational YouTube channel that features glaucoma surgical techniques called Eye Glaucoma. In 2021, she was voted to Ophthalmologist's Top 100 Power List of the most influential female figures in ophthalmology globally. She's a proud mother of 3 and happily married, and really a pleasure to have you join us. I've had the opportunity to work with you in the past. One of your close colleagues next to you, Dr. Walt Whitley, is a really close friend of mine. And it's just a real pleasure that you would take the time to be here with us, Dr. Okeke.
I'm excited to be here. Thank you for having me.
And Justin, I have to interrupt you for a second. It irritates me a little bit that it's the top 100 females. I think I would just say Dr. Okeke is just in the top 100.
Are you too kind?
Agree more with you on that, Danica, 100%.
Thank you.
And having you three here are easily top 100 doctors in my mind. So I'm just excited to be here with you guys because I've had a chance to work with all of you. And the knowledge that you're going to throw out here over the next 50 minutes is going to be amazing. And we're going to throw some tough topics at you because this is hot topics in glaucoma. So this isn't going to be just a simple run of the mill like, does IOP matter in glaucoma? We all know that matters. Questions are going to be other things. So let's jump into one. So we'll start off with something maybe that, let's talk about primary medical therapy. So we'll start with something easy, and I'd love to hear your guys' thoughts. A lot of discussion on primary medical therapy. We have glaucoma drug delivery that's on the market. We have new data, new studies with the LIGHT study coming out about SLT. We obviously have great topical glaucoma medications. And so I'll start with you, Danica. I'll throw this one to you to start with. In your mind right now, where is primary medical therapy for glaucoma at in this day and age?
Well, I'm a little bit older than you, so keep that in mind. I really typically start with meds. And I think we have such excellent, well-tolerated medications that's typically what I recommend. I usually offer SLT as a first-line option. And I think for a lot of us, myself included, it's a little bit trickier for me to get SLT for my patients. So I can write a prescription right then for a medication. They go to the pharmacy, they get started on their therapy right now. If I want to get SLT, I either have to refer them out of my facility or I have to wait until my glaucoma surgeon comes into my facility to get it. And it's just a little bit less convenient. So I will offer it as a first-line therapy, but I typically start with medication.
Dr. Okeke, I'd love to get your thoughts. Obviously being an ophthalmologist, you have access to SLT. And so your thoughts on primary medical therapy right now and in the world today.
Well, I do offer my patients a medical treatment first, as well as laser treatment first, and it could also be surgery first. And so it kind of really depends. So anytime I diagnose someone with glaucoma, I will always tell them about the 3 different classes of medication or classes of treatment, which include medications, different classes of medications, anywhere from 1 to 3 times a day, in addition to light energy treatment. I do specifically call it light energy treatment as opposed to calling it laser, because I do think as I have changed the terminology with patients, they do have a much more accepting idea of what the technology is when they think of it as light as opposed to laser. A lot of people think of laser different ways and it cutting. Okay, so in terms of SLT, we all know that it's a very gentle laser. It's a cold laser. It's not something that is cutting like a YAG laser. And so it's gentle. And so I talk to them in that way about it. And then I also let them know that there's different surgical options. And often these are options for the patients who have cataract surgery. And so say, for example, a person comes in or referred to me for a cataract eval, the doctor was suspicious about glaucoma. Here I am going to suggest, okay, you have a visually significant cataract, let's take it out. And I let them know that medications are an option as well as laser and surgery, but because we're doing it at the same time, I might offer a surgical treatment as a first line. Now, mind you, before they leave the room, I will always let them know that glaucoma doesn't sleep. And so even though we're planning to schedule whether a laser or glaucoma surgery, I'm going to start you on drops today because I want to start the process. It also gives me opportunity to get data. Do they tolerate this medication? Is it something that can work well? Because I can get another data point prior to the procedure of what their pressures are. So that's something that that's how I practice.
Dr. Steen, anything to add to that in your practice and how you utilize first-line therapy in glaucoma?
The key here is that we're at a time where we have options for our patients and we can really work individually to determine what may be the best in a particular circumstance. So in our particular facility, when given multiple options to patients, we do find that most of our patients do opt for medical therapy as a first-line choice. That always depends on the individual circumstance. But it's something that, we've certainly come a long way, and to have multiple options for an open diagnosis or a new diagnosis of glaucoma is something that ultimately benefits our patients long-term.
Great. Yeah. And so that kind of brings us to the point, and I mentioned it earlier, when I said, there's SLT, there's topical glaucoma medications, but now there's also glaucoma drug delivery. So let's talk just briefly about glaucoma drug delivery. And I'd love your guys' input and thoughts on this. So we have a glaucoma drug delivery device on the market. We have Durysta available. How have you guys seen that, or how do you see that fitting into your practices, and how do you see yourselves utilizing glaucoma drug delivery? And maybe also the second end of that question would be, what about the future of glaucoma drug delivery? Does it supplant topical glaucoma medications at any point, or is it just going to be another tool in our toolbox? And feel free, whoever would like to jump in and take this first one.
Well, I'll start with, in terms of Durysta, I think that there are certain places where I feel that it's really great to use. And for example, I have a patient population, like I mentioned, I do a lot of SLT first patients. And as I've explained the opportunity for them to have SLT first or light energy treatment first, A lot of them are excited about the idea about not having to use drops. And so if the SLT procedure is effective, but not to target pressure, or not effective enough to just have them well managed, it provides us a good opportunity for patients to still be treated, but not necessarily having to use drops on a regular basis. I do think that in terms of topical therapy, there are patients who are very irritated and sensitive to drops. Anywhere we can try to decrease the load. I think of it kind of like, I mean, my whole goal is to try to take care of their glaucoma, keep them seeing, but then also do it in a way where they have the best option to be most compliant. And so if I can reduce the medicines by at least one and use the Durista, that's helping them with the amount of drops they have to put in each day, as well as the surface toxicity. So I do think that there are places for it. And there are, like we were talking, Jessica mentioned earlier, that there are, our patients are very individualized. And so it's great to have tools to help them individually. I think that with adoption of anything, it can sometimes take time. And so I don't see us just getting rid of the topical drops. I think that it's going to take some time before that happens, and that could be decades, just like we've been using MIGS for a decade, and there's still room for more adoption. But I do think that it's very exciting to be able to offer.
I mean, I think honestly, unless or until Durista gets additional approval for subsequent placement, I think that I see Durista more as kind of a stopgap, right? Maybe the patient is, awaiting surgery. They're doing poorly on drops or whatever. To me, I don't see it as a fully fleshed out long-term solution for patients. And I know we listened yesterday about some of the patients in the studies really having good IOP control, even with just one device. I still don't see it really as mainstream long-term therapy, but I'm open to changing that perspective. It's just kind of where I see it right now.
The long-term or the longer-term data is going to be really exciting from this particular implant. It's something that when we think about the concept of durability, this is something that is not new within eye care. We've certainly seen through management and treatment of retinal disease, these longer acting medications, and really how that has a big impact on the long-term care of these often chronic diseases. So any type of medication that has this improved durability, no matter how that medication is getting to the eye, is something that really, is certainly positive and certainly something exciting that I see coming ahead.
Yeah, it's a great technology that I think all the points you guys made are spot on. Danica, agree with you 100% that, it's a technology that I've utilized a lot, and it's been really great for kind of patients that maybe are suffering from ocular surface disease, need a short drop holiday, but I have to have a backup plan. I have to have something ready to go because glaucoma is a marathon. It's not something that we're going to be able to cure, and there's going to be need to another treatment. So really, really good points about all that with glaucoma drug delivery. Connie mentioned a point about ocular surface disease. She brought that up. So I think that's the next question I want to go to here is how important in our glaucoma patients is it to address ocular surface disease? Because it can be easy to forget about treating ocular surface disease, especially when we're dealing with a condition that can cause blindness. And so we're managing pressures, we're looking at OCTs, we're looking at visual fields, and the patient's concern is, well, am I losing my sight? But a lot of these patients are suffering from ocular surface disease. We know this from studies. And so I'd love to hear your guys' thoughts on the importance of addressing ocular surface disease in our patients and how you do that and how you manage that in the setting of glaucoma. And I'll go ahead and have Jessica, why don't you lead us off on this particular one?
So it's a huge challenge for our patients, not only our patients that use topical medications, but certainly all of our patients. When we think about glaucoma patients, they're typically older individuals. And when we think about patients who have true dry eye disease, they're often, in general, there's an increasing prevalence with older individuals. So these groups overall overlap to begin with. And then when we think about topical medications, I think we're doing a really good job as far as patient counseling and really discussing the condition of glaucoma with our patients, which is why we are seeing overall good adherence to medication, but really in often cases, significant disease that patients are tolerating. So, when we think about tolerability of medications, certainly we've got some patients that one topical preserved agent, just tips them over that edge where they're uncomfortable and really have a significant impact on their quality of life. Where others, they come in with significant surface disease, and we talk to them about that surface disease, and they say, well, it's bothersome, but considering the alternative, I know I have glaucoma, I know that I need to be on probably some form of topical therapy. Our patients are willing to go through a lot based on their understanding of what glaucoma is. I think it's something to keep in mind that even if we completely take away preserved topical medical therapy, that is not going to cure these patients' dry eye disease. When we think about the DEWS 2 report, we know that it's a multifactorial condition. So just removing topical preserved agents is not enough to cure their condition, but it's certainly something that I like to address not only with additional topical medications, but also with in-office therapy that we work with our dry eye service for in-office treatment to try to improve the quality of the meibomian gland secretion and the meibomian glands in general of a more holistic approach.
I think it's really disheartening to think that what I'm doing in many cases may actually be causing a problem, right? We don't want to cause problems by treating a different problem. I think yesterday I kind of admitted that for a while I was kind of like, la, 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 I can't hear you. I'm not going to pay attention to your surface disease because all I'm going to do is look at your glaucoma. And I hope I've gotten away from that a little bit. But I think there's a real difference in making a diagnosis of glaucoma and they already have ocular surface disease. Those are the patients that I'm going to not just offer SLT, I may recommend SLT as a first-line therapy versus the patient who really doesn't have that much going on ocular surface disease wise when you make the diagnosis, but they develop it over time. And so, I have to say it's insidious in its onset, and sometimes it's hard to recognize, or maybe I just don't want to recognize it. It's a huge problem. And I think that the light trial data, the Durista and other interventional things that are really coming to the forefront now should help. But I think that, looking at that the first time you're making a diagnosis of glaucoma is really important.
Yeah, I agree with you guys. I think that in terms of the dry eye disease, I agree that if I see it before I've even as I'm diagnosing the patient, I will definitely recommend SLT strongly as a very good option for the patient. I think that we have to just be very mindful of all the different things that we can use, be familiar with the different drops that do have some advantage in terms of the ocular surface, like the preservative-free medication, Zelpro, Zioptin, Cosap PF, Timoptic, and Ocudose. And then also some of the drops that have preservatives that might be lighter, like Zelpros. I've had good experience with that, and using Travatan Z, even Alphagan has a different other than BAK. So it's important for us to at least be aware of these different options so that we can utilize them. Also compounding drops, taking, I've made a lot of use of that, taking multiple generic medicines, putting them in all one bottle and having decreased amount of drops, as well as, the frequency and then the toxicity on the surface. Those are all things to be just aware of so that we can try to help, because I think that in terms of early disease, when patients are not very aware that they have any vision loss, it's sometimes very hard, even if you educate them well, for them to embrace the vision threatening aspect of glaucoma. Some of them will, they're just worriers. They'll be like, oh, I want to do whatever I need to do. But some of them will still be kind of hard to understand the severity when they're really seeing pretty well. And so if you are not addressing that ocular surface and making sure that they're comfortable, they may not be being compliant. And, because of some of my research in the past with compliance studies, I did a study on rothetan dosing aid and looking at patients with once-a-day medications, and still found that a large proportion of them, 45% of them, were still not taking their drops, up to at least 70% of the time. And so it's important for us to really address these dry eye issues and not just assume that they're doing their drops well. I mean, we'll be surprised how fooled we are with how great we think they're doing when they tell us, because they just want to please the doctor. So all the modalities that we can use to try to cut things down. And yes, I agree with Jessica, trying to do extra efforts, trying to take away. I'm not someone who likes to add. I try to see if I can simplify, and then yes, do some of the other things such as vitamins, or using technology like iLux, LipiFlow, meibomian gland treatments to try to help with the underlying problem. So I do think that as glaucoma specialists, we do need to address it, because we're fooling ourselves if we don't. Because patients will find a reason why not to take it. I just don't feel good today, so I'm not going to take it for a day or 2 or 3. And those fluctuations can matter. So it's important for us to address it.
That always blows me away, your study, Hani, that you did. It's an amazing study. And it just, I'm always surprised by it, on the fact that these patients were given that medication for free and they knew they were being monitored and they still couldn't do it correctly. It's like, that's the biggest.
And then as we were monitoring them, and you're like, I'm such a good doctor, I educate so well, and I think Mrs. Smith is doing this, and she's like, yeah, I am. And then the test says completely otherwise. So we don't necessarily know what our patients are doing. And I think that was a real kind of something that hit me hard, to try to say, okay, I need to work on trying to simplify this regimen. All these patients on 3, 4, 5 different medications. I mean, sometimes it has to be that way, but as much as I can, let me try to reduce it for the reality's sake. Mm-hmm.
Great conversation. Thanks for that, everyone. And I'm going to shift a little bit to some diagnostic technology or diagnostic discussions. And this is a question that comes up a lot. I'll get this actually in my practice from doctors, and I'll be curious your guys' thoughts on this. So is OCT technology now standard of care if you want to manage glaucoma patients? And a pretty simple question, but one that, can sometimes get a little heated and a little complicated. Do you have to have an OCT to be able to manage glaucoma in 2021?
So I'll take this one to start off with. So I think that you have to have access to an OCT in 2021 to manage glaucoma. So I don't know that you necessarily need to have it physically in your office, but you need to have access to it. So whether that's a mobile OCT unit that goes around, we used to have one in Houston that would go to different practices and they would line up those patients on those particular days. Or if you send a patient to a colleague who has an OCT just for the technical component and you do the interpretation part, I think you really do. And I want to be really clear that I am firmly in the, you have to look at the optic nerve camp, right? I'm not the OCT is the king, but I really feel like the technology is here to stay. It's really valuable. We can certainly detect changes in an OCT that we cannot detect in our clinical exam. And so I think you have to have access to it. I know that may make some people mad.
I agree. I mean, when I think about how I treat glaucoma now, if I did not have the OCT to use as a tool to, whether, looking at the retinal nerve fiber layer or being able to evaluate the macula and slight changes that can happen there, and then using the progression analysis, I mean, all of those things really help to make my decision more definitive in terms of what I'm going to do. With a visual field, yes, those are definitely needed, but we all know that there's subjective issues that can happen with the field, or sometimes you have a field defect, it doesn't quite match how the nerve looks, but you might see something on the OCT that highlights an area that just makes sense. And so I definitely think that it's a must use. And I'm not saying that we shouldn't take fundus photos. I do still think that a picture is worth 1,000 words. And I think that there's definitely benefit to looking at the nerve and then documenting it. But I do think that OCT is something that if I didn't have, I would feel, of all the different diagnostic tools that we have, I would feel very limited because it gives me some very good information and gives me also a lot of reassurance when I see certain amounts of stability on the test and reverse signs of change that may not be as well picked up with some of the other testing.
Yeah, I completely agree. It's about the combination of structure and function. And structural evaluation, as you both said, of course, starts with the optic nerve and starts with our evaluation. But to have that objective structural information about the retinal nerve fiber layer and the ganglion cell analysis or ganglion cell complex interplexiform layer analysis, is certainly all part of that big picture. And I think as we're managing patients who are suspicious of glaucoma, and who may have glaucoma, it is about combining these different modalities of assessing structure and function.
We had a question pop up in the from the audience here, from the attendees, and it's a good question. It goes back to kind of the side effect profile of medications, goes back to kind of our ocular surface disease comment. And all of us, me included, have utilized a new medication out there called rothetan, which is a ROC inhibitor. The Mercury trial shows that it's very efficacious, does a nice job of lowering intraocular pressure. It's dosed once a day. But also what we found out in that Mercury trial, those Mercury trials, is that it can cause conjunctival hyperemia in upward of about 58% of patients. Kind of in the more of those patients, 50% be a mild to moderate. And the attendee's question is, have you guys noticed in your clinical practices, you've utilized this, some redness, and more importantly, because I think we've all seen redness with it, how do you address it with patients? What are some of your tips and tricks with it when you're utilizing it in your patient population?
I don't know if it's a trick or a tip, but I don't see the patient back for a month, because if you see them back in a week or so, they're gonna be like, my eyes are so doggone red. And I think sometimes it subsides a little bit, but also they just sort of get used to it. So I usually don't see them back for a month. And then I, sort of cautiously approach the subject. But that being said, I have patients who have discontinued because of the redness. Not a lot, but some. And you have to just respect the patient's right to reject a medication, even if it's working. I think the hardest part is when it's working really well, but the patient is not tolerating the side effects. Then it's a real bummer, because you're like, well, okay. But that's probably my biggest tip.
I think that it's important to let our patients know that the hyperemia is something that they should be, it's very highly possible that they'll expect it, okay, and that it's not harmful, that it has to do with the engorgement of the vessels, and so it's not something that is hurting their eye. It's just how the mechanism of how the drop works. I think that that's important so that they're not alarmed by the medication and assuming that it's something that's wrong. I think that it's also important, like Danica mentioned, that over time it can ease up. And then also it's not in everybody. And so sometimes the redness is something that it can be present. And from our level of tolerability, it might be a little bit more than we would want to handle. But we have to be respectful of the patients that sometimes when it's working well, they're okay. And if they're okay, we should also not be prejudiced and say, oh, I don't want to give you this medicine because it might make your eye red. There's a lot of people who, when it comes to glaucoma, they want to see. And their understanding a little bit of redness in the eye could be perfectly fine. And so we shouldn't limit using it because of our concern about the redness, but then talk through it. And in terms of, allowing them to, if it works really well, but it's red and they don't want to use it. The reality is that if they're telling you that they don't want to use it, they're not going to use it. So what's good is a drop that's going to stay in the drawer and not be used for their glaucoma. So you have to come up with a different alternative. So I think that it's a great drop. I've seen it lower pressures when patients have pressures in the low 30s, high 20s, and get it into the mid-teen range, and even sometimes the low teen range. I've seen that before as well. So it can be a very effective drop. So we just kind of have to kind of talk them through it and let them know that it can get better. Also, one other thing is sometimes the Lumify drop can help a little bit. The over-the-counter Lumify drop helps with the redness. It can help a little bit. I've seen that help with some PGAs in that class.
I think there's certainly exactly that overlap that certain patients, even with PGAs, have that tolerability concern of the redness that occurs. And just the same way with any particular medication, including Nutraceuticals, there are patients that I find don't tolerate it as well as others, but those patients are generally few and far between. Most patients do tolerate it extraordinarily well, and it often works, as you said, even much better than what we may expect. I find especially when the intraocular pressure is on that lower side, or a patient who may have normal tension disease.
Connie, you're like a mind reader. As soon as you were making those comments about Lumify, a question popped up. Can you use Lumify? So we didn't have to address it because you addressed it so beautifully.
Well, but also just remember too, though, that we were just talking about the impact of everything that we use on patients' ocular surface disease. So yes, we can. I think we want to do it judiciously, prudently. Oh, you're going to a wedding? Yeah, certainly use your Lumify, but are you going to use it 3 times a day? Probably not, right? So just be careful.
Well stated. Yes, exactly. Well stated. Another question came in because we were talking about OCT technology, and the doctor's asking, he has an older technology OCT. Is it necessary for him to upgrade to the new generation technology, or can he still could use that older generation type of technology? Any thoughts on that?
One of the concerns, with a time domain system, especially evaluating patients with glaucoma, is the macular analysis. And that's something that, we're certainly at a point where we understand the importance of macular analysis and ganglion cell complex analysis in patients who may have early disease or with established glaucoma in detecting early progression. So that is something that, when you're thinking about newer technology versus older technology, I think evaluation of the ganglion cell complex is something that we certainly should be evaluating.
Yeah, and also the ability to do progression analysis in a way where you can create that contour line that is able to each time find and lock onto those structures and be able to assess the level of progression. When you're using the older technology, you're just trying to get in around the same area, but it's not exact. And so it's more helpful for when you're diagnosing something as opposed to using it to follow. So then without having the progression analysis and not having the ability to evaluate the ganglion cell complex, you're now losing 2 major areas of the advantage of the OCT. So is it really worth, spending the money for the older generation as opposed to being able to get access to the newer one? I would lean towards trying to get access to the newer technology because I'm sure it's going to continue to change. You don't want to be so behind the curve.
Excellent, excellent points. So next topic of discussion. So I have a bunch of patients that come in. I'm in a tertiary care center. I work alongside a glaucoma specialist cataract surgeon. I have patients all the time that come in and are interested now more than ever in presbyopic correcting implants for their cataract surgery. There's good technology out there, it continues to get better. And really right now we have great technology, trifocal IOLs, extended depth of focus IOLs. So we have all this technology, but our glaucoma patients will ask me about it as well. So I'd love your guys' thoughts on, can glaucoma patients have advanced technology or presbyopic correcting IOLs? And would you offer it to them? And I'd love to hear you guys' thoughts on that.
So I don't know if Connie should go first or last because she's got the surgeon's perspective, right? But this is an optometric meeting, I think, for the most part. So I'm just going to say one thing because then I really want to hear what Connie says. You have to talk to your patients about advanced technology IOLs because if you don't, the surgeon will, and they need to have heard it going into the surgeon's office. So that would be my first thing is you can't ignore it. You can't put your head in the sand. Some lenses like aspheric lenses, toric lenses, those all should be fine. And I think that even multifocal lenses probably for ocular hypertension or very early glaucoma would be appropriate or could be appropriate. I would really shy away from a multifocal IOL in a patient with moderate to severe glaucoma because they're going to decrease contrast sensitivity. I think they're going to you're going to have problems with your visual fields as well as just functional problems for the patient due to 2 different things potentially decreasing contrast sensitivity. And I'm going to be quiet because I can't wait to hear what Connie says.
Really quickly, we talk about options and the importance about options. Connie, what's your take on this?
Yeah, so I have been dabbling in the use of advanced technology lenses for glaucoma patients for some time, and I have been really excited about some of the technology that we've had over the last year to 6 months in terms of access to really great results for patients who have glaucoma, not just in your mild ocular hypertensive type patients, but patients who are even in the more moderate and in some cases even slightly going into severe, moderate severe. Okay, so there is the Vivity lens with Alcon that I've been very excited about because it is a non-diffractive IOL that gives excellent distance, excellent intermediate, and very good near, very good functional near. And because of it, the way that the lens is designed, it has a way to not split light, but to stretch light. And so that the ability to still maintain good contrast and good vision, even in dim light, is there. And so I've been using this lens and I've been very excited about it because all my patients have been doing excellent in terms of their vision. I typically do combine these lenses with the MIGS procedures and have been excited to be able to offer this. Now, when I counsel my patients, I let them know that up until recently, for your level of glaucoma, if that's the case, we haven't really been able to offer patients this type of opportunity for this extended range of vision lens and still get good quality vision, but we can. And so as you counsel the patients, they're excited about having something that they didn't know if they would be able to have access to. But is also very important is to create the level of expectation for these patients. You are not taking away their glaucoma. And so it is imperative that every single time at the time of the evaluation, I will show them their visual fields, and they have to have the recent visual field for them to be able to assess where their glaucoma is. And I'll explain that this is a visual field, this is where the normal blind spot is, and a normal visual field looks like this, with the area all light in color, okay? And so the areas that are dark are areas that are the blind spots because of your glaucoma. And a cataract is like a film on top of this, and I'll put my hand over it, and I'll take the film away when we take the cataract away, and what's left, the areas that are light in color, those are the areas that can get brighter and more defined, but those areas that are dark will stay dark because this is the permanent glaucoma. So in the areas where you can see well, you can have that extended range of vision. And so it's kind of one of those things where you say it should, you know, with patients, and especially when they have binocular vision, you should allow them to try to, in the areas where they can see the best that they can. And so with this lens, I've been able to do that. And I'm also excited about the Johnson & Johnson Eyehance lens, which I'm now starting to use as for my toric cases, because it is a lens that has been improved for ability to see very excellent at distance and excellent intermediate. It is shy of the standards that were needed for it to get that extended depth or extended range with the near, but sometimes it does pretty decent at near. But I've been using it for my patients who I use for my toric lenses, or my patients who have just a little bit of astigmatism and do femtosecond laser for their LRIs, and to just create and to relax a little bit of astigmatism, because it gives them, and I talk to them about how you're going to have excellent distance vision, but now they also have that excellent intermediate, which they don't necessarily have with the standard toric lens. And so and then sometimes they have a little bit of near, so it gives them a little bit more advantage, and it has an excellent ability to give very good contrast, not reduce contrast sensitivity. And so I'm very excited about those two technologies, really ramping up my ability to add to the volume that I was doing already with my patients. Prior to, I had been using in patients who had very minimal visual field loss, I was using a active focus lens for the multifocals for my patients, and I had pretty good results with that. But you have to be this has to be very minimal glaucoma in terms of the visual field loss, nothing close to the visual central fixation. And like I said, with the Vivity lens, I've had some patients, and some of the visual fields I've seen, and they were ecstatic and they're doing great. And they had some areas where there was some encroachment near closer to fixation, and like I said, in the areas where they can see well, they can see to have the extended range and be very excited about their vision. So I'm happy about that. I'm happy to share this with doctors to let them know that it's not like a sentence to the patient. You have glaucoma, so you're just going to get the standard. Toric lenses should be a slam dunk. I've even had patients who have had really very constricted visual fields, but they could have a good vision in that area. Remember, there's one gentleman in particular, he just wanted to be able to fish without glasses, and I put him in toric lenses, and he's been a happy camper, and his glaucoma has been stable, and he's kept those that area of vision centrally and done great. So I won't necessarily shy away from toric lenses for patients as long as I explain to them where they are in the state of their glaucoma and what is expected that I would be able to do in the area where they can see. And so having that dialogue and discussion makes for a patient who's satisfied after the surgery and very happy.
I have a nerdy question. So it has to do with testing visual fields in a patient who's had some type of multifocal IOL, because they have some near vision. They probably don't have, do they have 33 centimeter vision that's good? Is it not good enough? Do you still put an ad in? And I know that probably a lot of people don't care about that, but it really makes a big difference in your visual field if the patient is clear. So what trial lens do you use in a patient wearing a multifocal lens?
That's a good question. I can't say that I have done anything differently from what I normally do with my visual fields in terms of testing and assessing them for distance vision, to be honest. So I don't put it, I don't change it for patients who've had multifocal lenses and haven't had a noticeable impression of a change in the visual field or difficulty with that as a result. So it's a good question, but I can't say I've changed anything from my routine in order to assess or make a difference for that.
Thanks.
This is a topic that is definitely not going away with, the IOL technology that's coming out, with just the fact that our glaucoma patients are going to be well informed. They're getting inundated with it. They find it themselves, and they're going to keep asking the questions. So thank you for all those excellent points. So we have about 10 minutes left. So I think we can get through a couple more subjects, but we did have a question come up from the audience again that I think is worth addressing. And the question was, do any of you talk to your patients about nutritional pieces in regards to glaucoma? And I will tell you flat out that, I talk to my patients about good nutrition. I talk to them about, not smoking, those types of things, but I don't per se just target that at my glaucoma patients. So I'm interested, you guys target your glaucoma patients and talk about anything specifically in regards to nutrition? And by the way, we have a great 1-hour lecture coming up by Dr. Eric Conley here in a little bit, where he will definitely dive into nutrition with glaucoma as well.
That's what I was going to say, is just stay tuned, because Eric's going to talk for about 40 minutes, I think, on nutraceuticals and glaucoma. I don't specifically make recommendations, but I might after 3 o'clock Houston time.
Any other comments?
Yeah, I mean, I will talk to patients about decreasing caffeine intake, making sure that it's not heavy, because there are associations with increased caffeine and increasing pressure in glaucoma. I'll talk to them about eating green leafy vegetables and citrus fruits, because there have been some studies that have shown some association with that being helpful or healthy to the optic nerve tissue. And then there are some over-the-counter pharmaceuticals that I suggest using. There's a optic nerve formula by, I think, Ocular Science Health, Ocular-based science. It is a compilation of a number of different components that have been, through research, evaluated for their effect on the optic nerve, either increasing blood flow or helping with reducing antioxidants. And I think that it's something that I've had some patients who even mentioned they felt that their vision improved in terms of the color. And so it's something that I, especially with my patients who are more advanced, that are looking for something else to be able to use, that I suggest.
Away a little bit from directly nutraceuticals, but something that we do talk about with our patients, and often they bring up with us, is asking about, and it's always that question, is there anything else, or is there something else? And when we talk about exercise habits, healthy diet, healthy eating habits, but when we talk about exercise, we know that light aerobic exercise can have an impact, and thinking about mindfulness and meditation. Now, the yoga discussion, of course, is always one that does come up, and holding strenuous poses for periods of time, especially when they're inverted, are things that we know significantly elevate intraocular pressure. But when we think about general mindfulness, meditation, and upright, kind of low impact yoga poses, those are things that overall can have a gradual downward shift, although slight, to intraocular pressure.
Excellent.
Yeah, to be honest, I think that anything that helps reduce stress can be something that's going to be beneficial to the body, and including the optic nerve. And I agree with you. I mean, I think that when patients are, sometimes, there are certain things that can happen in medicine that we can't explain, we can't really measure. But I do think that if there are things that can help just overall health and also decreasing stress, like you said, mindfulness, meditation, I think that those are things that can only help, whether in the disease process or in, say, wound healing after they've had surgery. So I agree with you there.
So last one, we're going to throw this one out there. And the way we'll kind of do this is I'll have Jessica and Danica take the first part of the question. I'd love that Connie could take the back part of it. And so the question really involves with insurance companies or insurance systems, they obviously impact a lot of what we do. They impact of us getting, diagnostic exams paid for, obviously medications, and then surgical things. So let's focus on the medication piece. How has insurance systems impacted the medications you're able to prescribe? And that's the one I'll throw at Jessica and Danica. And then the second part, Connie, I want you to comment on is how has that impacted the surgical procedures in the glaucoma world that you've been able to utilize? So Jessica and Danica, I'll have you take that first piece first.
We know that we practice in a really complex healthcare setting that is seeming to become more and more complex. And certainly being aware of that as step one and how that impacts our patients, of course, may make the difference between the ability of our patients being able to get a medication that we may prescribe to them or not. So often what this means in my particular practice is understanding that a step-based therapy may be needed. Generic medications and the availability of generic prostaglandin analogues has been something that has certainly helped our patients as a whole. And understanding that in particular circumstances, we may have preferences for maybe not a generic prostaglandin analog as a first medication of choice, but understanding that it is often a very affordable option and is often a good starting place for our patients. So I think kind of one step at a time. And I will say that in our particular practice, generic prostaglandin analogues are often the most common starting point of any topical therapy, and alterations, substitutions, and possibly additions thereafter are things that come next. But I think starting with a generic PGA is something, keeping in mind insurance limitations and insurance possibilities is something that's really realistic and ultimately has been and is often a very effective medication choice.
Yeah, for the patients who have commercial insurance but aren't, so they're not Medicare or Medicaid, there are often great copay cards. I think I said this yesterday, but anytime my doctor prescribes a brand name product for me, the first thing I do is Google the name of that medicine and copay card, because you can take a medication. My daughter was on an acne medication. I'm sure she would be thrilled for me to tell that to everybody, but she was on a medication. I went to the pharmacist. They said it'll be $385. And I said, she's going to have pimples. And then I Googled, whatever the medicine was, copay card, and it was like $35. So, I want people to understand that there are ways to help your patient access medications. And I think when new medications come out, the first thing that we hear is, oh, but it's going to be expensive. And it is true. But oftentimes there are, drug company representatives who can help you navigate the prior auth piece of it, to help you navigate the stepped process of it. So generics are here. Generics are going to be part of what we do, but I don't think that we should just throw up our hands and say, I'm never going to get a branded product. There are ways to access branded products for many of our patients.
Great, thank you. And the last 2 minutes, Connie, I'd love to hear your perspectives on the surgical side of things.
Yeah, I think that then the surgical side, insurance definitely has made some limitations on the things that we offer. So in terms of my exam, when I'm looking at a patient, one of the things I'll ask my scribe are what are their MIGS options? And what that means is what are the insurances, the MIGS that will be covered by this insurance for the patient. So as I'm looking at the eye, I can kind of get a sense of which one that I would choose. Now, sometimes it's actually beneficial to me because a patient could have multiple options that could fit based on their eye anatomy and the stage of their disease. And sometimes it helps me limit it. So it's not like a kid in a candy shop. I'm like, which one do I choose? I mean, so sometimes actually helpful. But when it's something, when I have in mind something I really want to do, and then it's like not something that's covered by the insurance, and I'm like, okay, I have to pick the next best thing. I've now started to actually sometimes discuss this with the patient. If it's something I really want for them, because I really think that this particular device will work, I'll let them know that this is what I really would want. It might be something that you might have to pay out of pocket. And I want to say that because just like advanced technology IOL, we give the patient the option to choose and pay out of pocket for those things. Same thing could happen with a patient with glaucoma. If you have a surgeon that really thinks that this particular surgery would work best for you, it actually is a disservice for us to not even mention it, to see that they might be able or willing to pay for it, because sometimes they do. And at least have in your mind the backup plan for the next best option if this one doesn't happen, which is what we'll do anyway. So it has made an impact, insurance, and it's sometimes unfortunate, but there are still some ways around it. And the best thing to do is arm yourself with as many mixed procedures as you can, so that you can have multiple things to offer to your patient. That's been a wonderful thing for me to be able to have. I don't feel as limited because I can go from here to here to here to here, being able to know all the available technologies and offer them to my patients.
Well, thanks so much. Boy, we ran out of time. It's time already. And I had still some more questions to ask, and we could probably go another hour, to be honest with you, with the information that, you all were able to provide. So I just want to say it's been an honor to be able to do this with the three of you. Thank you for your time and making the time to spend it with me, and just your knowledgeable answers about glaucoma and everything we just talked about. So I would love to do this again with you anytime. And so thank you so much for your time.
I'm just going to put a plug for my iGlaucoma YouTube channel. A lot of the topics that we've talked about today, there's some videos on it that are could be very helpful. So iGlaucoma YouTube channel. Thank you. I had a great time. It was great being with all of you, and thank you for the opportunity to be here.
And before we leave, one thing, a raffle code. MIGS, we got to get that out there. So go to the exhibit hall with this little break coming up, visit with some exhibitors, take that code, get your raffle tickets, and enjoy the rest of the meeting.